The abdomen functions as a diagnostic black box. Gastrointestinal, genitourinary, vascular, and endocrine systems share a cavity lacking bony protection. Standard exams follow a linear path: inspect, palpate, percuss, auscultate. To maintain diagnostic integrity, the abdominal algorithm dictates a strict deviation: inspect, auscultate, percuss, palpate. This sequence functions as a physical diagnostic algorithm engineered to isolate variables without introducing iatrogenic artifacts into the clinical data. This video deconstructs the anatomical, acoustic, and physical first principles that mandate this specific order of operations. Adhering to the IAPP sequence prevents the clinician from corrupting their own evidentiary baseline before the diagnosis even begins. Passive visual assessment serves as the starting point, allowing the clinician to gather structural baseline data without physically disturbing the abdominal cavity. The clinician scans the abdominal wall for specific cutaneous markers of retroperitoneal hemorrhage. Periumbilical ecchymosis, or Cullen sign, and flank ecchymosis, known as Gray-Turner sign, provide immediate indicators of internal bleeding. We can map internal vascular pathologies by observing the direction of venous blood flow on the abdominal wall. In a healthy state, blood flow moves upward above the umbilicus and downward below it. When the arrows below the umbilicus reverse direction and flow upward, it signals a severe obstruction of the inferior vena cava. The body is using the abdominal wall as a collateral pathway to bypass the blockage. This presentation is distinct from caput medusa, which is caused by portal hypertension. Here, blood is forced to bypass a diseased liver, radiating outward 360 degrees directly from the umbilicus to reach systemic circulation. Rigorous inspection allows the clinician to non-invasively map deep vascular obstructions and hemorrhagic events directly onto the surface of the skin. Auscultation must immediately follow inspection because the gastrointestinal tract is highly sensitive to mechanical pressure. Palpating the abdomen before listening causes an artificial spike in bowel motility. This mechanical stimulation corrupts the acoustic data before it can be recorded. A normal acoustic baseline consists of low-pitched gurgling sounds occurring at a rate of 5 to 35 times per minute. When the gut is straining to overcome an early mechanical small bowel obstruction, the acoustic shifts to high-pitched, tinkling rushes. Completely absent bowel sounds, confirmed only after 2 continuous minutes of listening, indicate a paralytic ileus or diffuse peritonitis. After assessing the bowels, the clinician shifts focus to vascular acoustics, specifically at the aorta and the bilateral renal arteries. Identifying bruits in these specific regions provides evidence of arterial stenosis or aneurysmal dilatation. Securing an uncorrupted acoustic baseline is the only reliable method for measuring autonomous physiological motility before the clinician's hands interfere with the system. Perpression involves the deliberate mechanical testing of underlying tissue density through sound wave reflection. The technique yields 2 distinct acoustic responses: low-frequency tympany, reflecting off air-filled viscera, and high-frequency dullness, reflecting off solid organs or fluid. By identifying these acoustic boundaries, the clinician can accurately map and measure the liver span along the right mid-clavicular line. These same acoustic boundaries allow us to evaluate for ascites. This diagram illustrates the fundamental physics of buoyancy within the peritoneal cavity. Free fluid gravitates dependently to the flanks, while air-filled bowel loops float at the surface. The shifting dullness test confirms free fluid. When the patient rolls laterally, internal densities shift with gravity, moving the boundary line. While fluid shifts, fixed adipose tissue or solid masses maintain their dullness borders regardless of the patient's position. Percussion leverages basic physical laws to non-invasively map the hidden, shifting boundaries between solid, liquid, and gas. Palpation is the final and most invasive step of the algorithm. It is used to provoke targeted neuroanatomical responses. The visceral peritoneum lacks somatic innervation, dictating the initial perception of pain. Visceral inflammation results in dull, poorly localized pain. In early appendicitis, pain radiates vaguely across the central periumbilical region. This contrasts with the parietal peritoneum, which possesses dense somatic innervation. As the inflamed organ touches the parietal wall, diffuse waves vanish, replaced by a sharp somatic signal localized precisely at the lower right quadrant. True abdominal rigidity is an involuntary somatic muscle spasm, a reflex reflexively shielding the inflamed viscera from further contact. We confirm peritonitis through Blumberg sign or rebound tenderness. The rapid release of deep palpation abruptly stretches the inflamed peritoneum, eliciting a sharp pain response. The primary clinical hurdle is voluntary guarding. Patient anxiety and the anticipation of pain can cause muscle tension that mimics true rigidity, corrupting the diagnosis. Clinicians bypass voluntary guarding through adaptive techniques, such as using a stethoscope to palpate while pretending to listen, or performing examinations on an infant in the knee-to-knee position. Masterful palpation separates psychological anxiety from true somatic nerve reflexes to pinpoint the exact anatomical layer of peritoneal failure. Modern clinical assessment relies heavily on advanced diagnostic imaging, such as CT scans and ultrasounds. While these modalities provide static anatomical data, they cannot offer real-time physiological feedback or live pain mapping. The IAAPP algorithm acts as the essential physical bridge over this diagnostic gap. Strict adherence to this sequence isolates vascular flow, acoustic peristalsis, tissue density, and neuroanatomy, ensuring each variable is measured without cross-contamination. Mastery of the IAAPP sequence prevents premature diagnostic anchoring, allowing the clinician to dictate the precise urgency and modality of subsequent surgical or imaging interventions.